Welcome back, guys. This is a part 2 of the thyroid lecture, and here we're specifically going to focus on specific thyroid disease and random thyroid nodules. It's going to be a relatively short lecture. I want to keep it simple, what you need to know for the surgery shelf. The rest of the stuff you're going to cover in your internal medicine reviews. So some of the questions you want to consider is, how do you evaluate hyperthyroidism? What are the common causes of hypothyroidism? Complications of thyroid disease? How would you treat Graves' disease? How would you treat Hashimoto's? And a very high-yield topic of thyroid storm, and how would you manage that? Back to our famous chart from the previous lecture is how the thyroid hormone works. So keeping it simple, your thyroid gland makes T3 and T4. If your T3 and T4 are high, that means it's primarily a thyroid gland disease. So primary hyperthyroidism. If they're high, primary hyperthyroidism, T3 and T4, primarily because your thyroid gland is making too much of them. So what would that cause? If you have too much of T3 and T4, it'll go back and suppress your TSH. Right? And a secondary one, so how do we discuss a secondary disease in endocrine is because of the stimulus. So if you have a secondary hyperthyroidism, is because what's your stimulus is your TSH. So a secondary hyperthyroidism would be if you have an anterior pituitary tumor, it will cause too much TSH, which will cause your thyroid gland to make T3 and T4. Some of the things that T3 and T4 do, they increase your metabolism. So how would that manifest? Increase body temperature, weight loss, so some of the things like that, growth and development. So remember in our endocrine lectures, we covered why the thyroid hormone is important is because if babies don't have a thyroid when they're born, that's called thyroid hypoplasia, they will have mental retardation because the brain needs thyroid in the first couple of years of life in order to grow. And we discussed that in MEN2 and 2B, when they have a thyroid cancer, you don't remove it before the age 1. So you want to make sure the kid grows, the brain develops, and then after that you'll prophylactically remove it. And another thing that you want to focus on is increased catecholamine effect. Catecholamines, your sympathetic effects. What would that cause? So common thing that you would see is increased heart rate. So that's one of the signs of hyperthyroidism, especially if it's a long-term disease. So some of the hyperthyroidism clues that we covered, weight loss. So if they say somebody comes in over the past 4 weeks, they lost 10 pounds without trying, they haven't been exercising, they haven't been dieting, that should already say hyperthyroidism to you. Increased pulse pressure. This is like the sneaky way they put the questions into you. So what do we say increased pulse pressure was? So pulse pressure is the difference between your systolic and your diastolic blood pressures. And if they tell you increased pulse pressures, automatically 2 diseases should come into your mind. And what were they? Aortic insufficiency and hyperthyroidism. There's other causes for increased pulse pressure, but these are the 2 common diseases they want you to get at. Heat intolerance. Remember, you increase your metabolism, you generate heat. So you'll have increased heat in your body, so you'll always feel warm. Women will get irregular menses. So since you'll have now catecholamine effects, right? If you're having it all the time, you're having increased heart rate, you'll develop atrial fibrillation. The sneaky fact that women will have a lot of people with long-standing hyperthyroidism will have a mitral valve prolapse. And how would that show up on the exam? They would say a mid-systolic click. Fine hand tremor. How would that manifest? You put your hand, they would describe a patient who would lift their hand, close their eyes, you could see their fingers wiggling. And hyperreflexia, increased catecholamine effect, everything is a lot faster, right? So I think with too much thyroid, your body is just revved up. Essentially, you drank too much coffee. So with differential diagnosis, what should you think of when you see hyperthyroid patient? So this is what they primarily ask you. Hypothyroidism, there's not many things they're going to ask you on the surgery shelf, but they will ask you about hyperthyroidism. We talked about the toxic adenoma and multinodular goiter in part 1 of our lecture, right? Essentially, there's just one or multiple nodules that just oversecrete thyroid hormone. Graves' disease, the most common cause of hyperthyroidism in the United States. Postpartum thyroiditis, subacute thyroiditis, infectious thyroiditis, and Hashimoto's, which can cause thyroiditis. So don't get confused by this. Initial phase of thyroiditis will cause hyperthyroidism. The reason why is your thyroid, apart from making the thyroid hormone, it will also store some thyroid hormone inside it. Why? Because, for example, if you get stressed enough, your body needs a bolus of thyroid hormone. Where is it going to get from? From your thyroid gland, right? So it keeps it in there. Now, thyroiditis, think of it as an infection or an attack on the thyroid. It would be bacterial, viral, or autoimmune. you have stored thyroid hormone in there. So you attack it. So during the initial phase, what's going to happen? You're just going to spill all the thyroid hormone out, and you're going to get hyperthyroidism. Now, you're still damaging the thyroid gland, right? Now, once all those hormones wear off, right, what's going to happen? You're going to become hypothyroidism. So that's why it's important to realize that initially you will have hyperthyroidism and thyroiditis, and then you can develop hypothyroidism. So somebody comes in with signs and symptoms of hyperthyroidism, the first test you do is you take TSH. Well, that was the same thing in a nodule, right? You want to make sure if they're actually having hyperthyroidism versus if they're just taking too much other medications. So that's first test you'll do is a TSH. Now, if your TSH is suppressed, you want to measure your T4 level, right? You want to make sure if the disease is from the thyroid or is it exogenous. Is the thyroid making too much T4, or versus are you taking too much T4? Some of the herbals, or think of an anorexic patient who wants to, do a lot more weight loss, so they would take, over-the-counter thyroid hormone analogs and things like that. Second test that you do, yes, you measure the free T4. So you take the TSH to make sure if they're hyperthyroidism, if that is low, that is telling you the thyroid, there's something wrong with your thyroid hormone levels, right? And then you measure the T4 to see if it's from the thyroid or it's not from the thyroid. Remember, we said in primary hyperthyroidism, your thyroid is going to make too much T4, so you'll have a lot more T4. So you measure that. Now, before we go on further, I block these because there's some random things there that's esoteric and just going to confuse you guys. But these are widely available on the web if you want to search an algorithm for it. I just want to keep it simple to what you need to know, because there are some diseases there that will not be on the surgery shelf, and you're just going to end up confusing yourself a lot more. So somebody comes in with hyperthyroidism, you measure their TSH level, that was suppressed. So you measure their T4 level. That's first and second test. Your T4 is high. That means your thyroid is making too much hormone, right? So what do you want to do? You want to find out if it's actually your thyroid that's making. How would you find out if your T4 is coming from your thyroid versus if you're taking, for example, medication? Well, remember what we talked about? Thyroid likes iodine. And we have two types of iodine, right? Iodine 123, which you use for imaging, and iodine 131, which you use for essentially killing the thyroid, right? Their level of radioactivity is different. So you do a radioiodine thyroid uptake. Now, if that is high, we'll talk about these diseases. What if it's low? What do you want to think of? So if your thyroid uptake is low, then it's because you have thyroiditis. That's the thing they will ask you about. Remember, you damaged your thyroid. Your thyroid secreted all those T3 and T4 into the bloodstream. You're having symptoms of hyperthyroidism. But your thyroid is not making hormones currently, right? It's because it got damaged. So your uptake is going to be low. Your uptake only goes up when you're actively making the thyroid hormone. The thyroid just got damaged. It secreted whatever stores it had. It's not making hormone right now. So initially, thyroiditis, you'll have hyperthyroidism symptoms. That means low TSH, high T4, and a low uptake. Are we all clear on that? So what else would cause similar symptoms if it's not if it's not thyroiditis? What if you're just taking T4, right? You're taking T4, for example. They have herbal stuff. You could find it on black market. Weight loss supplements, right? That's how the question will go. You're essentially taking T4, right? You're going to take T4, so that's going to suppress your TSH, but your free T4 is going to be high, right? But your uptake is going to be low because your thyroid is I'm not making any T4 because you're taking by the pill, okay? So thyroiditis, and you want to think of exogenous T4. So which kind of thyroiditis? The history will tell you. If you delivered the baby recently, right? That's going to be postpartum thyroiditis. And a postpartum thyroiditis is painless. I don't want to go into the reasons why, because there's just a lot of things that go here, but it's essentially not high yield, but postpartum thyroiditis can show up on an exam. You just got to recognize postpartum thyroiditis. It'll tell you delivered the baby a couple of weeks ago, a couple of months ago. If you recently had a viral illness, you had a cold, a viral illness, So they would not necessarily describe a fever. For example, if the patient felt malaise, tired, they were having a runny nose, they were sneezing a lot, a mild cough. So think of a viral illness, upper respiratory infection, for example. It's called subacute thyroiditis or decurvent thyroiditis, whichever. There's a lot of names. That's whichever one. I just like to remember it by viral thyroiditis. And that one is painful. So that's a hint. Postpartum is painless. Subacute is painful. So what would you have? They will tell you some labs. You'll have an elevated ESR. So what does ESR stand for? It's erythrocyte sedimentation rate. And that's just a marker of your inflammation, right? So if you're having inflammation, you could treat with steroids and aspirin, which is a non-steroidal anti-inflammatory. We want to decrease the inflammation down. But you don't do any kind of surgery, it'll kind of subside down the road. Now, if they describe you a tender thyroid, you have fevers, and you have an immunocompromised patient. For example, if you have a hyperthyroidism patient or a thyroid disease patient who got PTU or methimazole, right? What does that cause? Granulocytosis. That increases your infection risk. And that's usually caused by staph and strep. So what I would focus here, a tender thyroid is both there and here. It's the fever. It's the fever that I would focus on. And this one will give you elevated ESR versus not here. Now, obviously, you don't want to give steroids to somebody who has an infection, so read the question carefully. Who gets viral illnesses? Usually like young people, so this patient will be younger than the patients here. So some of the little clues that you see on the exam. Now, we discussed about the low uptake. Let's talk about the high uptake. So if it's nodular, we talked about the nodular ones. If it's multiple, it's toxic multiple nodular goiter. If it's a hot area, it's a toxic adenoma. So we discussed this in a part 1 of lecture. You could go in there and review it. If it's diffuse, if your whole thyroid is taking up the iodine, then it's the famous Graves' disease. Graves' disease, most common cause of hyperthyroidism in the United States. So why is this little sentence of most common cause of hyperthyroidism important? As you know, the shelves are notorious for giving you 1-line or 2-line questions. So you read a question and this patient has hyperthyroidism or they have a low TSH, right? And they give you 15 answer choices of what this might be. Essentially, that's what they're asking you. What's the most common cause? They're not giving you any hints in the history. It's a 1 or 2-line question. Essentially, they want you to know what's the most common cause of this. So you want to pick the Graves' disease, right? What is Graves' disease? It is an autoimmune disease. So your body makes an activating IgG antibodies against the TSH receptor. There's a lot of names there for it. Some of it is a thyroid stimulating antibodies, which I like. It actually tells you what it is. It is a thyroid stimulating antibody. It stimulates your thyroid. Or another name for it is a TSH receptor antibody. This is a little bit, so you got to realize that's why I put the activating there, because if you use a TSH receptor antibody, realize it's going to activate that TSH receptor rather than kill it. All right, so essentially what you're doing, you're activating your thyroid gland. What is it going to make? You're going to make tons of T4 and T3. So, and you have TSH receptors all over your thyroid, right? So your whole thyroid is going to take up iodine. So that's why it's called diffuse radioiodine uptake. And common thing, unique to the Graves, it's not the fact that you have hyperthyroidism, you get exophthalmos. The receptors, these receptors actually have these antibodies have receptors around in the connective tissue of your eye. So what does that cause? It causes those connective tissues around the eye to enlarge. And you get this characteristic of this is the picture of the radioiodine uptake here. So this is a normal. There's not much uptake. You're going to uptake some, right? Because you're still making the hormone. Here, you just uptake tons. Your whole thyroid is making hormone. This is the exophthalmos that I was talking about. So connective tissue gets big. What if the connective tissue behind the eye gets big? It's going to push the eye out. So they're not going to tell you this patient has exophthalmos, because then obviously they're going to give you the answer. What do they tell you? They have a lid retraction. They have a bulging eye. So watch for those things. It's a very characteristic exam that shows up on exam. And this is very unique and characteristic of Graves' disease, not hyperthyroidism. The reason is because those antibodies cause the hypertrophy of the connective tissue behind the eye, and the connective tissue will push the eye out. You don't get that with other hyperthyroidism disease that we discussed earlier. Typical presentation, you'll have the hyperthyroid symptoms. Pretubular edema is also very unique because remember, think of those receptors attaching to your connective tissue, and it's going to kind of make hypertrophy. Exophthalmos, unique for it. It's more common in women. So women have higher chance of autoimmune disease. So Graves and Hashimoto's that we'll discuss later, which autoimmune thyroid disease, are more common in women. So that's going to be a typical case. And AFib, they'll always tell this patient, you read the vital signs, they'll have a resting heart rate of like 115, and sometimes they might describe that's irregular. So you want to watch out for that too. The treatment. So since your whole thyroid gland is taking up iodine, that means you could use that iodine to your advantage. So here you use iodine 131. So don't get confused by iodine 123 and 131. 123 is lower than the 131. The higher number is dangerous because it's higher and it kills. 123 is for imaging. So you use iodine 131 to think of it as a poisonous iodine. Your thyroid's going to take up, and that poisonous iodine is going to kill your thyroid gland. Right? You rarely need surgery in somebody who has Graves because this iodine therapy works very well. Now, remember from a previous case, when might you not want to use radioactive iodine? Correct. In somebody who's pregnant, or who really doesn't want iodine surgery, right? Who doesn't want radioactive stuff injected into them. So if in that case, you could do medication, PTU or methimazole. Remember, PTU is safe in pregnancy, methimazole is not, and it could cause agranulocytosis, increase your infection risk. PTU more than methimazole, but essentially they both cause the same risk. If this doesn't work and the medication don't work, then you could do a total thyroidectomy. Now, if the answer choice gives you partial thyroidectomy, don't pick that because you have around 50% recurrence rate, versus with total thyroidectomy you have like 2 to 5%. So you pick the total thyroidectomy. And make sure when you go surgery, before they go to the surgery, you want to control their risk factors, right? Remember, increased thyroid hormone causes increased catecholamine effects. And how would that manifest? Increased heart rate, right? How would you block the catecholamines? Remember, the beta receptors cause increased heart rate. You beta blockers, right? For elevated heart rate. That's one of the things they will tell you about. So this is where we discuss the thyroid storm. So there are a lot of people who could have Graves' disease and not have symptoms, right? Or they have hyperthyroidism and you're operating on them for some other reason. For example, you have Graves' disease and you haven't diagnosed yet, and somebody comes in for an eye surgery, for a hand surgery, or some surgery that's not related, right? And during the surgery, they tell you that this person has symptoms of fever. They're starting to have arrhythmias and they go into coma. You want to think of thyroid storm. Right? Now, when we said fever, arrhythmias, and coma during a surgical case, we had to think of three things. You either think of pheochromocytoma, thyroid storm, or a coma, or neuromalignant syndrome, neuroleptic malignant syndrome, and that's essentially allergic reaction to anesthetic. Right? How do they differ? Pheochromocytoma, they'll tell you history, a family history, or something in the MEN2A or MEN2B. So you want to watch out for those. Neuroleptic malignant syndrome, that will give you fever, and remember the characteristic feature is it will cause an increase in tidal CO2. Other ones don't cause that. So as soon as they say that your CO2 is going up, and so you got to worry about neuroleptic malignant syndrome. In thyroid storm, they will tell you that this patient is either having Graves' disease or having symptoms of hyperthyroidism, and they're getting surgery for that. Or they will tell you about hypothyroidism symptoms, but they're having surgery for their hand or something. They will give you a hint. You got to think of those three things and rule them out. How do you manage thyroid storm? So there's, first, you want to control their heart rate. The arrhythmia is going to kill you, so you use a beta blocker for the arrhythmias, and you give them PTU to stop your T3 synthesis. You start stopping synthesis of the hormone. That's your first line. After you give those two, you give iodine and hydrocortisone. So let's start with the hydrocortisone first. What is the hydrocortisone going to do? It's going to prevent conversion of T4 to T3. T3, remember, is the potent form of thyroid hormone, and the T4 can be converted to T3, and you don't want to have that. You don't want to, because have a lot of potent thyroid hormone in your bloodstream. So you give them hydrocortisone. The steroids will prevent the conversion. What does iodine do? So this is not going to show up on your exam, but it's going to show up on the wards. They're going to ask you why you give iodine for thyroid storm management. Think of this thing called, from back in the day when you were learning physiology, it's called Wolff-Chaikoff effect. When you give too much iodine to someone really fast, your thyroid essentially thinks there's too much iodine, it's just going to shut down. It's like, oh, I have too much supply. It's called the Wolff-Chaikoff effect if you want to go read about it, but If it's highly unlikely the question will ask you this, but remember, first thing you want to control something that's going to kill you. It's the beta blockers because it's the arrhythmia that's going to kill you, and then you give the PTU to stop the hormone synthesis. Rydell's thyroiditis. I put this here because sometimes it ends up showing there, and people can get that confused with cancer. So what it is the thyroiditis is an infection of attack on the thyroid. So Rydell's fibrous stroma is another name for it. It actually tells a lot about the disease, right? It becomes fibrous, so it's a very rare disease. It's progressively getting thick, and the thyroid starts to harden, right? And it's painless. It may resemble lymphoma or a mass, right? Because, I mean, anaplastic carcinoma of the thyroid, for example. So you biopsy it, right? And it shows Rydell's. And you only operate in the case if you have compressive symptoms. Now, if you're going to progressively thicken the thyroid and make it into a fibrotic tissue, you're going to become hypothyroid down the line. And when it happens, you start replacing the thyroid hormone with levothyroxine. Hypothyroidism. Essentially, for hypothyroidism, you need to know just one disease for a surgery shelf, and that is Hashimoto's. What is Hashimoto's? It is the most common cause of hypothyroidism in the United States. So it's a shelf question. You get a one-liner. This patient has symptoms that are similar for hypothyroidism, right? What are you going to think of? You think of Hashimoto's first. What are some symptoms of hypothyroidism, right? Everything kind of slows down. So opposite of hypothyroidism. You're constipated. Heart rate is slow, you're gaining weight, you're cold all the time because your metabolic rate is low. So essentially opposite of hyperthyroidism. And what is Hashimoto's? So essentially anti-thyroid peroxidase antibodies. So thyroid peroxidase essentially converts everything into thyroxine, into your T4 and T3. So you're blocking these enzymes, so obviously it's going to become trapped in the thyroid. You're not making a lot of hormone. And antimicrosomal antibodies. I would remember these because this is just show up randomly. It's like an easy question to ask. They will tell you there's antibodies in the bloodstream. That's Hashimoto's. Question can describe that they biopsy the thyroid, and there's a lot of lymphocytic infiltration. Remember, if you have a long-standing Hashimoto's disease and there's a lot of lymphocytes in there, you can get what's called thyroid lymphoma. It's very rare, but shows up on the exams once again. And it could describe Hürthle cells in your biopsy report. What is that? Is eosinophilic inclusion bodies. That's what they're not going to say Hürthle cells, but they're going to say there's a lot of eosinophilic cells in the biopsy. Don't get that confused with Hürthle cell carcinoma. That's totally a different thing. Hürthle cell carcinoma is a subtype of follicular cell carcinoma. Don't worry about that. Don't confuse yourself. If they say Hürthle cells, which is this, they will describe this, not Hürthle cells. So that's all you need to know. Hashimoto's, and just move on. Treatment. Obviously, Hashimoto's causes hypothyroidism. You replace the T4 with levothyroxine. And you don't need to do a surgery unless they develop a lymphoma or something. So it's very rare that you do a surgery for Hashimoto's. Watch out. So remember, Hashimoto's can cause thyroiditis. What is the initial symptom of thyroiditis? Is hyperthyroidism, right? They will tell you a patient with hyperthyroidism with this antibodies, anti-thyroid peroxidase, antimicrosomal antibodies, right? So you gotta be like, well, this doesn't make sense. Yes, it can make sense because initial stage of Hashimoto's can cause thyroiditis, which will cause hyperthyroidism. This antibody is easy to remember because if you just look at this enzyme, you know that makes the T4. If you block that, obviously you're going to become hypothyroidism. So that's easy one. And antimicrosomal is the one that you actually just actively commit to your memory. But no matter if you have hyperthyroidism or hypothyroidism, the antibodies will be there, and it will tell you that on a question. All right. So we come to the end of the lecture. So lab test, remember we start with the TSH, then you measure the T4, right? And if your T4 is high, then you go measure the radioiodine to see if your thyroid is making the hormones, if your thyroid, or you're taking exogenous thyroid hormone. Common cause of hypothyroidism, the most common cause is Hashimoto's. What are the complications of thyroid disease, right? If you have a lot of thyroid storm, that could be if you have a lot of thyroid hormone, irregular menses, you could get AFib, and if you have irregular menses, that can cause osteoporosis down the road. So there's a lot of complications because it's not healthy to live in a heart rate of 130 and increased metabolic rate all the time. How would you treat Graves' disease? Remember, Graves' disease is a diffuse uptake. So you do iodine 131, so radioactive iodine. If you don't want to do that, if there's a pregnant patient or there's other contraindications that they tell you in the question, then use PT or metamazole. If that doesn't work, then you do a total thyroidectomy. Don't pick subtotal, pick total. Hashimoto's treatment, essentially you replace the hormone, which is the T4, which is levothyroxine, and if the patient develops lymphoma, you take out the thyroid. And thyroid storm management, just worry about the things that will kill you. Is arrhythmia. That's one of the things that will kill you, so you give them beta blocker. And then after that, you give PTU. Those are your first two managements. And then the second line management is going to be iodine and your steroids. So I would really remember the beta blockers, PTU, and the steroids. The iodine is not highly likely to show up on your exam. And with that, we conclude our lecture.